Langerhans cell histiocytosis is a proliferative disorder affecting Langerhans cells, which are immune cells continually patrolling for invading microbes as part of the body's immune system. With Langerhans cell histiocytosis, mutated cells infiltrate different body systems where they can cause damage and form lesions called granulomas. Symptoms of Langerhans cell histiocytosis vary depending on the body systems affected, ranging from isolated lesions in the skin, bone, or lungs to systemic disease affecting multiple body systems. Common skin manifestations include eczematous rashes over the body, brown or purple skin bumps, and bleeding ulcers, especially behind the ears and in the scalp. Now, if lesions occur in bone, they usually develop in the skull and long bones of the arms or legs, causing localized pain and swelling, as well as increased risk of pathological fractures. If the skull or facial bones are affected, there is increased risk of central nervous system dysfunction, especially damage to the pituitary gland, a hormone-secreting gland located at the base of the skull. Pituitary gland dysfunction can result in extreme thirst due to excessive urine production, a condition known as diabetes insipidus. In severe cases, neurodegeneration can lead to cognitive dysfunction and behavioral issues, as well as ataxia, or difficulty with coordination when walking. Next, Langerhans cell histiocytosis in the lungs is more common in adults due to its association with smoking and is characterized by shortness of breath, chest pain, and cysts that can sometimes rupture and cause the lungs to collapse, leading to spontaneous pneumothorax. Lastly, in cases of multisystem disease, Langerhans cells may accumulate in the liver or spleen, leading to hepatosplenomegaly, as well as in the bone marrow, where they can crowd healthy blood-forming cells resulting in low blood counts. Individuals may also experience nonspecific symptoms such as fever, weight loss, and fatigue. Alright, now diagnosis of Langerhans cell histiocytosis may include laboratory blood tests, a complete skeletal survey, which involves a series of x-rays of all the bones in the body, a whole-body CT scan, or MRI of the central nervous system to look for abnormalities in the brain and pituitary gland. Pulmonary function tests, as well as bronchoscopy, may be done in cases of lung involvement. Ultimately, diagnosis of Langerhans cell histiocytosis is confirmed through a biopsy of skin, lung, or other affected sites, which will show infiltrates of inflammatory cells with abnormal Langerhans cells. Treatment of Langerhans cell histiocytosis is based on which body systems are affected and whether the disease is isolated or systemic. Skin lesions in infants may resolve spontaneously during the first year of life without treatment. Other individuals with only bone or skin lesions may be treated with local surgery, radiotherapy, or steroid injections. On the other hand, if Langerhans cell histiocytosis is found throughout the body or affects high-risk organs like the brain, liver, or spleen, treatment typically involves systemic treatment with chemotherapy, immunotherapy, or targeted molecules like vemurafenib or dabrafenib, which prevent the growth of mutated Langerhans cells. Alright. As a quick recap, Langerhans cell histiocytosis is a proliferation of mutated immune cells that have the ability to infiltrate body systems such as the skin, bones, and lungs. It can range from isolated lesions to multisystem disease. Treatment depends on which organs are affected, including observation, localized treatments, or systemic therapy with chemotherapy, immunotherapy, or targeted molecules.
Mastocytosis, or clonal mast cell disease, is a rare disorder that leads to increased numbers of incorrectly functioning mast cells. Mast cells are a kind of white blood cell that have many roles in the immune system, including allergic reactions. There are two main categories of mastocytosis. In cutaneous mastocytosis, the mast cells accumulate only in the skin. In systemic mastocytosis, mast cells also accumulate in other tissues like the liver, spleen, lymph nodes, gastrointestinal tract, and most commonly, bone marrow. Generally, the signs and symptoms of mastocytosis are similar to an allergic reaction. They can range between categories and from mild to life-threatening. Some examples are pain, flushing, malaise, headaches, memory and concentration difficulties, stomach aches, production of more than the usual amount of gastric juices, abdominal discomfort, nausea, bloating or diarrhea, and anaphylaxis, which is a severe allergic reaction that can be deadly. Now, within each main category of mastocytosis, there are additional forms. Their distinction can be based on more specific signs and symptoms. For example, in the most common form of cutaneous mastocytosis, lesions appear on the skin's surface as brownish, flat, or elevated spots. They may be surrounded by Darier's signs, which are areas of skin that become red and itchy when scratched or rubbed. In the rarest form, lesions aren't present, but the skin is rougher and thicker. Itching and blistering may also occur in individuals who are less than 1 year old. Some skin changes may be present in systemic mastocytosis, but these forms also involve dysfunction in other tissues. Blood cell production in the bone marrow may decrease, and bones may soften and weaken. In addition to liver dysfunction, swelling or enlargement of the liver, spleen, or lymph nodes may occur. In aggressive systemic mastocytosis, liver function may be lost, and in advanced mastocytosis, other blood disorders such as leukemias can form. Normally developing mast cells are found in the bone marrow, and as they mature, they leave the bone marrow and sit in tissues around the body. There they have an important role in activating the immune system to defend the body against a threat, such as an insect sting, alcohol, or physical or emotional stress. When a threat triggers a response, mast cells become activated and release a large amount of chemicals, like histamine or leukotrienes, into the surrounding tissue. These chemicals lead to a specific immune system response called an allergic reaction. Typically, mastocytosis is caused by changes or mutations in the KIT gene, also called mast stem cell growth factor receptor, and the most common mutation is D816V. This leads to abnormal growth and accumulation of mast cells in tissues and overactive release of chemicals, sometimes without a clear trigger. The effects of the chemicals involved in these allergic reactions leads to many of the signs and symptoms of the disorder. Mastocytosis can affect males and females equally. Cutaneous mastocytosis more commonly occurs in children, typically resolving during puberty. Systemic mastocytosis largely affects adults and tends to persist throughout life. A diagnosis of mastocytosis can be confirmed by a biopsy of the affected tissue. A skin biopsy for cutaneous mastocytosis or a bone marrow biopsy for systemic mastocytosis would reveal a high number of mast cells. With systemic mastocytosis, mast cells in the bone marrow may also have an abnormal appearance and commonly have the D816V KIT mutation. Treatment for mastocytosis centers on management, particularly the activity of mast cells. Chromoglycic acid can be used to prevent the release of chemicals. But if chemicals are released, their effects can be dampened by medications like antihistamines or leukotriene antagonists. Anaphylaxis can be managed using EpiPens. In some cases, glucocorticoids may be used to reduce immune system activity. Specific signs and symptoms can be managed further. For example, psoralen plus ultraviolet A radiation, or PUVA, can treat skin lesions. Bisphosphonates can strengthen bones, and proton pump inhibitors can be used to treat the increased acid production in the stomach. In aggressive systemic forms, specialists like hematologists or oncologists may be needed to target more aggressive management. Several medications have been approved by the FDA to treat aggressive systemic mastocytosis, including imatinib mesylate, if not associated with a D816V KIT mutation, midostaurin, and most recently avapritinib. As a quick recap, mastocytosis is a rare disorder characterized by abnormal accumulation and activation of mast cells in body tissues. It can be divided into two main categories, with cutaneous mastocytosis primarily affecting the skin. Systemic mastocytosis affects the bone marrow and internal organs like the liver, spleen, gastrointestinal tract, and lymph nodes. Signs and symptoms, which are generally similar to those of an allergic reaction, can vary between categories and types. Mastocytosis is usually caused by mutations in the KIT gene. A diagnosis can be confirmed through tissue biopsies, and treatment is focused on managing mast cell activity and the effects on specific tissues.
Myelodysplastic syndromes, or MDS, are a group of rare blood disorders associated with faulty development of blood cells in the bone marrow. MDS can affect individuals of all ages, but it's more common after the age of 60. Blood cells develop from the hematopoietic stem cells through a process called hematopoiesis. This involves a number of divisions and eventually results in three types of blood cells: red blood cells, which carry oxygen around our bodies, white blood cells to help fight disease-causing pathogens, and platelets that help form clots to stop bleeding. Once these cells are fully mature, they leave the bone marrow and enter the bloodstream. In MDS, hematopoietic stem cells are damaged, so they give rise to faulty blood cells, which don't mature, but instead persist as immature cells called blasts. These immature blood cells usually die in the bone marrow or soon after they go into the blood, so you can't really count on them to do the job of mature blood cells. As the condition progresses, immature blood cells gradually take over the bone marrow, which displaces and reduces the normal ones. In most cases, the cause of MDS is not known. When this happens, it's classified as primary MDS. In rare cases, they can be caused by chemo or radiation therapy, and this is called secondary MDS. MDS comprises a spectrum of diseases, with differing potential for remaining stable or progressing to acute myeloid leukemia, or AML. The most common feature of MDS is anemia, caused by low red blood cell levels. Symptoms of anemia include dizziness, irritability, headaches, and pale skin. Low white blood cell levels increase the risk of bacterial and fungal infections. Finally, low levels of platelets cause excessive bruising following minimal injury and easy bleeding. Now, MDS usually worsens with time, as normal bone marrow function diminishes. 40 to 50% of the time, MDS deteriorates into a form of cancer known as acute myeloid leukemia, or AML. This happens when there are more than 20% blasts in the bone marrow. Diagnosis requires a variety of specialized tests, including complete blood counts, a peripheral blood smear, as well as bone marrow aspiration and biopsy. On a complete blood count, there may be low levels of 1, 2, or all of the 3 blood cell types. On a peripheral blood smear, there may be big and oval-shaped red blood cells and abnormal white blood cells and platelets. The bone marrow sample may show an increase in cell count with dysplastic changes in the 3 blood cell types. Chromosome analysis may find genetic abnormalities in affected cells. Treatment of patients is dependent on their clinical risk status, like their risk of developing leukemia or remaining stable. Patients' risk status is determined by their complete blood counts, the proportion of immature cells, or blasts, in the marrow, and the type of chromosome abnormalities present in the bone marrow cells. This information is used to generate a score known as the International Prognostic Scoring System, revised for MDS. Other features now being evaluated are the presence of mutations in the patient's cells, some of which are associated with a poorer prognosis. Treatment of lower-risk patients is generally aimed at improving their blood counts. Growth factors like erythropoietic growth factors can be given weekly to stimulate the production of red blood cells. In addition, patients with a chromosomal abnormality known as 5q- can be effectively treated with the drug lenalidomide. In some cases, people with MDS respond to immunosuppressive therapy with anti-thymocyte globulin. Treatment of higher-risk patients is aimed at preventing the patient's disease from progressing to leukemia. Standard treatment includes the use of hypomethylating agents like azacitidine or decitabine. In addition, for these patients, a bone marrow stem cell transplant from a healthy donor may be an option and is the only curative treatment for MDS. Some treatment for MDS is also supportive and involves red blood cell transfusions to correct the anemia, platelet transfusions to treat or prevent serious bleeding, and antibiotics to treat or prevent infections. Sometimes, multiple transfusions may cause an iron buildup in the body, so an iron chelating agent, like deferasirox, may be needed to eliminate it from the body. All right, as a quick recap, myelodysplastic syndromes, or MDS, are a group of rare blood disorders where blood cells don't mature properly in the bone marrow. In most cases, the cause is unknown. Complications of MDS are either chronic low blood counts or the potential to develop acute myeloblastic leukemia when there are more than 20% blasts in the bone marrow. MDS is associated with symptoms of anemia, easy bruising, bleeding, and increased susceptibility to infections. Diagnosis requires complete blood counts, a peripheral blood smear, bone marrow aspiration, and biopsy. Treatment depends on the patient's risk status, and in addition to specific drugs, includes red blood cell transfusions to correct the anemia, platelet transfusions to treat or prevent serious bleeding, and antibiotics to treat or prevent infections. A bone marrow transplant from a healthy donor is the only curative treatment for MDS.
Essential thrombocythemia is a slowly progressive disease where the bone marrow produces too many platelets. In rare cases, essential thrombocythemia can develop into myelofibrosis and acute leukemia. Now, the vast majority of bone marrow is made of hematopoietic cells, which are the early progenitor cells that can then differentiate into other types of cells. In case of platelets, progenitor cells differentiate into megakaryocytes, which are responsible for creating platelets. In essential thrombocythemia, there's a genetic mutation that occurs in the Janus kinase 2 gene, also called JAK2, or somewhere along this pathway of cell signaling. Normally, the liver and kidneys produce a tiny hormone called thrombopoietin, which binds to hematopoietic cell receptors. When it binds, those cells activate the JAK2 gene, which makes them divide and mature into megakaryocytes and platelets. Cells can also develop mutations in the thrombopoietin receptor, MPL, or in the chaperone protein, calreticulin, or CalR. Now, when there's a genetic mutation in CalR, the signaling pathway remains active all the time. And that means that platelets keep getting produced even in the absence of thrombopoietin. Although there are lots of platelets that are made, many of them end up being misshapen. They're large and irregularly shaped. Now, all of these excess platelets end up causing an increased risk of blood clots in the deep veins of the legs, lungs, and even sites where clots don't usually form, like the abdomen. As a result, there's an increased risk of stroke, heart attack, and miscarriage. Now, if the number of platelets is extremely high, over 1.5 million, then there's an increased risk of bleeding. That's counterintuitive, but it's because platelets use up free von Willebrand factor, and low concentrations of circulating von Willebrand factor means that it may not be enough available at the site of an injury, and that can lead to bleeding.
Now, some individuals with essential thrombocythemia can have symptoms like fatigue, headache, dizziness, nausea, tinnitus or ringing in the ears, and numbness in the hands and feet. But more commonly, essential thrombocythemia is usually found unintentionally when elevated platelet levels are found on a routine complete blood count. If essential thrombocythemia is suspected, a bone marrow biopsy can be done to confirm the diagnosis. Typically, lots of unusually large megakaryocytes can be seen on a bone biopsy. Treatment of essential thrombocythemia depends on risk of blood clots. For young and healthy patients who are at low risk of blood clots or bleeding, sometimes we give aspirin and monitor the platelet counts. When the risk of blood clots is high, therapy usually involves lowering the platelet count by using medications like hydroxyurea, interferon alpha, and anagrelide. In individuals with extremely high platelet counts, platelet pheresis can be used. That's where platelets are collected and removed from the blood before the blood is returned to an individual. Alright, as a quick recap, essential thrombocythemia is a slowly progressive disease where the bone marrow produces too many platelets. Most often, it's identified unintentionally on a routine blood test. Medications like hydroxyurea, interferon alpha, and anagrelide can be used to lower platelet counts and decrease the risk of clotting.
A 70-year-old female named Jenny is brought by her husband to the emergency department complaining of blurred vision and headache. Her face appears plethoric, and her husband says that Jenny has been complaining of extreme itchiness after showers for the last few days. She has no significant past medical history. CBC shows increased hematocrit and slightly increased platelets. Uric acid is also increased. Next to Jenny, there's a 65-year-old male named Seth that came in with fatigue and progressive weight loss due to early satiety. Past medical history is unremarkable. Clinical examination reveals a very enlarged spleen. CBC shows pancytopenia, and peripheral blood smear shows teardrop cells. Jenny and Seth suffer from myeloproliferative neoplasms. These are a group of malignant neoplasms characterized by proliferation of the bone marrow cells from the myeloid lineage. That includes red blood cells, platelets, as well as granulocytes, which include neutrophils, basophils, mast cells, and eosinophils. Each disorder can potentially cause proliferation of all of the myeloid cells, but they're classified based on the dominant cell line involved. So there's polycythemia vera for red blood cells, essential thrombocythemia for platelets, chronic myeloid leukemia, or CML, for granulocytes, and the odd one out, primary myelofibrosis, which doesn't really have a dominant cell line, but instead is characterized by bone marrow fibrosis. Okay, now CML is associated with a 922 translocation, which is when there's fusion of the BCR gene on chromosome 22 and the ABL tyrosine kinase gene on chromosome 9. This is called the Philadelphia chromosome. Now, in this video, let's focus on the myeloproliferative disorders that are not associated with Philadelphia chromosome, or the Philadelphia chromosome negative myeloproliferative disorders, like polycythemia vera, essential thrombocythemia, and primary myelofibrosis. All right, so let's take a closer look at these myeloproliferative disorders, starting with polycythemia vera, where there's an increase in red blood cell production. It typically begins with a mutation in a single hematopoietic stem cell, which gives rise to red blood cells, white blood cells, and platelets. In 90% of the affected individuals, there is a mutation of the gene that encodes for a non-receptor tyrosine kinase called Janus kinase 2, or JAK2. And that's something you absolutely have to remember for your exams. Normally, the kidneys produce erythropoietin, which is a hormone that binds to receptors on the hematopoietic stem cells and activates JAK2. When that happens, it causes the cell to divide and thus produce more blood cells. However, when there's a mutation, it keeps JAK2 activated all the time, and these cells are able to divide even in the absence of erythropoietin. This results in massive red blood cell production. The interstitial cells of the kidney sense the high levels of red blood cells, so they decrease erythropoietin production to keep the red blood cell levels normal. However, as the mutated cells proliferate, they rapidly become the predominant hematopoietic cells in the bone marrow, and this will keep increasing red blood cell levels. In time, these cells start to die out and lead to fibrosis of the bone marrow. At that point, the bone marrow can no longer produce blood cells, leading to anemia or low red blood cell levels, thrombocytopenia or low platelet levels, and leukopenia or low white blood cell levels. This is known as the spent phase. And once the disease is in the spent phase, it's really a different disease altogether. At that point, it's secondary myelofibrosis. The treatment of polycythemia vera include phlebotomy, hydroxyurea, or a JAK inhibitor, like ruxolitinib. Okay, next up is essential thrombocythemia, where there's an increase in platelet production. It can be caused by a genetic mutation in the JAK2 gene, like in polycythemia vera. Normally, the liver and kidneys produce a hormone called thrombopoietin, which binds to hematopoietic cell receptors. When it binds, those cells activate the JAK2 gene, which makes them divide and mature into megakaryocytes, which are responsible for creating platelets. But unlike polycythemia vera, only 50% of patients have a JAK2 mutation. They can have mutations in the thrombopoietin receptor, MPL, or in the chaperone protein, calreticulin or CalR. CalR mutations are present in 25% of patients. Okay, whatever the mutation, the signaling pathway remains active all of the time, and that means that platelets keep getting produced even in the absence of thrombopoietin. In rare cases, essential thrombocythemia can develop into myelofibrosis and acute leukemia. All right, let's talk about primary myelofibrosis, which, unlike secondary myelofibrosis, is not caused by another disease. This is why it's also called chronic idiopathic myelofibrosis. Okay, although primary myelofibrosis is a myeloproliferative neoplasm, it doesn't always cause a cell count elevation. That's because it results from an abnormal proliferation of megakaryocytes that, instead of making platelets, make cytokines, and a very high-yield one is platelet-derived growth factors, or PDGF. These cytokines stimulate excessive collagen deposition in the bone marrow, which replaces the hematopoietic stem cells, causing anemia. The white blood cell and platelet counts are variable and can be increased, normal, or decreased depending on how much of the bone marrow is fibrosed. For your exams, remember that 50% of patients with myelofibrosis have a JAK2 mutation, and 25% have a CalR mutation, and that's exactly the same as an essential thrombocythemia. All right, now most patients with myeloproliferative disorders don't have symptoms and are discovered incidentally when a CBC is done for another reason. But sometimes symptoms can occur and you have to remember them for the exam since they are very high yield. In polycythemia vera, all those extra red blood cells in the blood can make it sludgy and highly viscous. Hyperviscosity causes stasis in the circulation, which augments the formation of blood clots in different tissues, causing various symptoms. In the brain, they can cause blurred vision, headache, or strokes. Or in the heart, they can cause angina or myocardial infarction. Blood clots can also form in unusual locations, such as the stomach, where they can lead to peptic ulceration, or in the hepatic veins. They can result in Budd-Chiari syndrome, characterized by the triad of abdominal pain, ascites, and an enlarged liver. Also, the face can appear plethoric, which means a constant blush, because more red blood cells means more redness. Now, since myeloproliferative neoplasms can cause an increase in all myeloid cells, mast cells can also be increased in polycythemia vera. Therefore, pruritus or itching occurs after warm showers, and this is thought to be due to increased histamine release from mast cells in response to the heat. Now, the plethoric face and the itching after a hot shower are probably the best clues you can get on the exams for polycythemia vera. Now, a rare but characteristic presentation of polycythemia vera is erythromelalgia, which are episodes of redness and intense warmth and pain in the palms and soles, caused by small blood clots in the distal extremities. These blood clots can manifest from the hyperviscosity that predisposes patients to thrombosis, but can also be related to an increased platelet count in polycythemia vera patients. More red blood cell proliferation means more DNA and RNA synthesis, which results in more purine metabolism. Purines are metabolized into uric acid, and this increased metabolism can result in hyperuricemia, which can potentially cause gout. Gout usually presents with acute joint pain, particularly in the big toe. The spleen, which is a bit like a nursing home for old red blood cells, starts to get really filled up, resulting in splenomegaly. The enlarged spleen can push against the nearby stomach wall, causing early satiety and eventual weight loss. Moving on to essential thrombocythemia, some patients can have symptoms like fatigue, headache, dizziness, nausea, tinnitus, and numbness in the hands and feet. Also, they can get complications that are similar to polycythemia vera, like thrombotic complications, erythromelalgia, and splenomegaly because the spleen gets infiltrated by platelets. But pruritus is uncommon in essential thrombocythemia, and this can help you differentiate between the two on an exam. Also, if the platelet count exceeds 1 million, the platelets aren't able to function in such a crowded environment, and the patient becomes paradoxically predisposed to bleeding. Now, in myelofibrosis, all those extra cytokines produced by megakaryocytes can be released into the blood, triggering constitutional symptoms like fever, weight loss, and a decreased appetite. Additionally, once the bone marrow becomes fibrotic, it stops doing its job of producing new blood cells like red blood cells, causing symptoms of anemia like pallor and fatigue. Also, another high-yield fact is that backup hematopoietic organs like the liver and especially the spleen can get massively enlarged as they try to pick up the slack, a process called extramedullary hematopoiesis. Like in polycythemia vera, splenomegaly can lead to early satiety and weight loss. All right, now let's switch gears and talk about diagnosis. Myeloproliferative disorders are diagnoses of exclusion. So, for example, when you see an increase in red blood cells, or polycythemia, you have to think through all of the other causes before considering polycythemia vera. Polycythemia is when the hemoglobin level is more than 16.5 grams per deciliter in men, or more than 16 grams per deciliter in women, or a hematocrit more than 49% in men, or more than 48% in women. Women have a lower cutoff because they normally lose some blood through the menses. Now, on your exam, you might need to differentiate between polycythemia vera, which is also referred to as primary polycythemia, and secondary polycythemia, which is further subclassified into relative polycythemia, appropriate absolute polycythemia, and inappropriate absolute polycythemia. To differentiate the causes of polycythemia, we'll be looking at 4 laboratory parameters: plasma volume, red blood cell mass, oxygen saturation, and erythropoietin levels. So, starting with secondary polycythemia. Relative polycythemia happens when something like dehydration, diuretic use, or a burn injury causes a decrease in plasma volume, resulting in an apparent increase of red blood cells. But the red blood cells are only increased relative to the plasma. Therefore, we don't expect any change in the red blood cell mass, oxygen saturation, and erythropoietin levels. Now, a key concept that's frequently tested on the exams is appropriate absolute polycythemia, which is the physiological response to any cause of chronic hypoxia. That includes chronic obstructive pulmonary disease, or COPD, obstructive sleep apnea, which is characterized by recurrent episodes of asphyxia during sleep, congenital heart disease, or even hiking up a mountain. In response to the decrease in oxygen saturation, The peritubular cells of the renal cortex make more erythropoietin, which signals to the bone marrow to produce more red blood cells to compensate for the hypoxia. Over time, the red blood cell mass increases, while the plasma volume remains about the same. Now, inappropriate absolute polycythemia, on the other hand, is not some sort of normal physiological response. Instead, it occurs due to pathologic overproduction of erythropoietin from malignancies, such as renal cell carcinoma, hepatocellular carcinoma, cerebellar hemangioblastoma, leiomyoma, or pheochromocytoma. So, erythropoietin levels and red blood cell mass are increased, but the oxygen saturation and plasma volume are normal. Okay, so if you've excluded the secondary cause of polycythemia, it's time to consider polycythemia vera. The workup includes a CBC, which will show an increase in hemoglobin, hematocrit, and red blood cell mass, as well as a slight increase in white blood cells and platelets as well. Additionally, uric acid levels can be increased and erythropoietin levels are decreased. Also, a bone marrow biopsy is done, and the cells are tested for the presence of the JAK2 mutation. So, for your exams, you have to remember that the diagnosis of polycythemia vera hinges on having an increased hemoglobin or hematocrit and bone marrow biopsy showing increased proliferation of all myeloid cells, along with either a decrease in erythropoietin levels or the presence of a JAK2 mutation. Okay, on to thrombocytosis, which is defined as a platelet count of more than 450,000. The most common cause is reactive thrombocytosis, which is a reaction of the bone marrow to make more platelets when the body is experiencing something like bleeding, iron deficiency anemia, or inflammation. In inflammatory conditions like an infection, cytokines like interleukin-6 stimulate platelet production. In addition, since the spleen normally houses about 1/3 of the peripheral platelet pool, there can be a thrombocytosis in individuals that have had a splenectomy. Once these causes of thrombocytosis have been excluded, it's worth considering essential thrombocythemia. So, for essential thrombocythemia, a laboratory workup includes a CBC, which will show an increased platelet count and possibly an increase in the white blood cell count and hemoglobin as well. Iron studies including serum iron and ferritin levels can help rule out a reactive thrombocytosis due to iron deficiency anemia. The 4 major criteria for diagnosing essential thrombocythemia are an increased platelet count, a bone marrow biopsy showing an increase in megakaryocytes, identifying a genetic mutation like JAK2 or CALR, and not having an alternative diagnosis like polycythemia vera or CML. A minor criteria is the absence of any indicator of reactive thrombocytosis. To diagnose essential thrombocythemia, either all 4 major criteria must be met, or 3 major and 1 minor criteria have to be met. Finally, myelofibrosis can be primary, and that's the myeloproliferative neoplasm, or secondary, which is when it's the complication of leukemia, autoimmune diseases like SLE, toxins like benzene, or even glycogen storage diseases like Gaucher's disease. Now, once these secondary causes are excluded, primary myelofibrosis is considered. A peripheral blood smear characteristically shows teardrop cells, or dacrocytes, which are red blood cells that barely squeezed themselves out of the tight environment of the fibrotic bone marrow. Also, when attempting to aspirate a sample from the bone marrow, sometimes none of the cells are able to get out because of fibrosis, and this is called a dry tap. Okay, as a quick recap, myeloproliferative neoplasms are a group of malignancies characterized by proliferation of the bone marrow cells from the myeloid lineage. They're classified based on the predominant cell involved. So there's polycythemia vera for red blood cells, essential thrombocythemia for platelets, and chronic myeloid leukemia for granulocytes. There's also primary myelofibrosis, which is characterized by bone marrow fibrosis due to increased megakaryocyte that leads to collagen deposits in the bone marrow. In polycythemia vera, almost all patients have a JAK2 mutation, while in essential thrombocythemia and primary myelofibrosis, 50% have a JAK2 mutation and 25% have a CALR mutation. CML is characterized by the presence of the 922 Philadelphia chromosome, Most patients are asymptomatic and are discovered incidentally when a CBC is done for another reason entirely. Myeloproliferative disorders are diagnoses of exclusion. Now, back to the patients. Due to her symptoms of hyperviscosity, plethora, itchiness after showers, and the increased hematocrit, Jenny most probably has polycythemia. Secondary causes must be excluded in order to consider polycythemia vera, and erythropoietin levels will be low. To confirm the diagnosis, a bone marrow showing increased proliferation of all myeloid cells or genetic testing for JAK2 mutation must be done. Now, due to his symptoms of fatigue, massive splenomegaly, and pancytopenia with teardrop cells on the peripheral blood smear, Seth most likely has myelofibrosis. Bone marrow biopsy will be a dry tap, and to diagnose primary myelofibrosis, secondary causes had to have been excluded.
Myelofibrosis is a disease in which the bone marrow gets replaced by connective tissue in a process called fibrosis. Since the bone marrow's main role is to produce erythrocytes, or red blood cells, leukocytes, or white blood cells, and thrombocytes, or platelets, the process of fibrosis interferes with production of these cell types. Now, many cells in the bone marrow are hematopoietic progenitors, which are precursors to the different types of blood cells. In addition to these cells, there are fibroblasts, which are connective tissue cells. Now, myelofibrosis can be primary or secondary. Primary myelofibrosis is caused by a gene mutation within hematopoietic cells, which activates a signaling pathway called the JAK-STAT pathway. The mutation in the gene encoding the enzyme JAK2 activates the JAK-STAT pathway to go into overdrive so that the cells begin to mature and divide rapidly, quickly filling up the bone marrow. A large majority of these cells turn into megakaryocytes, which go on to make platelets. These megakaryocytes release cytokines, which are molecules that create inflammation. And one of these cytokines is fibroblast growth factor, which activates fibroblasts. The activated fibroblasts engage in the process of fibrosis, wherein they make lots of connective tissue that ultimately begins to fill up and scar the bone marrow and replaces hematopoietic cells. In response, the hematopoietic cells migrate to the liver, spleen, and lungs, a process called extramedullary hematopoiesis. These tissues enlarge and sometimes become dysfunctional. The extramedullary hematopoiesis is often not able to fully compensate for the loss of bone marrow hematopoiesis, and it can lead to a shortage of all blood cell lines, called pancytopenia. Secondary myelofibrosis can develop from conditions like essential thrombocythemia, which is where excess platelets are produced, and polycythemia vera, which is where excess red blood cells are produced. Common symptoms of myelofibrosis are bone pain, fatigue, itching, fever, and weight loss. Sometimes the extramedullary hematopoiesis can lead to hepatomegaly, splenomegaly, and pulmonary hypertension. In addition, the anemia can lead to fatigue, and the low white cell count, the leukopenia, can lead to frequent infections. The excess platelets can lead to thrombotic complications like deep vein thrombosis and pulmonary thromboembolisms. In myelofibrosis, there's typically an initial increase in blood cells, particularly platelets, but eventually those levels drop as there's pancytopenia. A blood smear will show abnormal, teardrop-shaped red blood cells, immature nucleated red blood cells, and immature white blood cells and platelets. A bone marrow biopsy can show an increase in hematopoietic cell numbers in early myelofibrosis, or a decrease in hematopoietic cell numbers and fibrosis later in the process. Erythropoietin can be given for anemia, and blood transfusion can be given for pancytopenia. The medication ruxolitinib can help inhibit the JAK-STAT pathway, and it relieves symptoms and specifically causes a reduction in spleen size. Alternatively, a hematopoietic stem cell transplantation, which comes with its own risks, can be done to potentially cure myelofibrosis in some individuals. Alright, as a quick recap, myelofibrosis is a rare bone marrow disorder where the bone marrow tissue is replaced with fibrotic tissue, and that interferes with blood cell production. Blood tests and bone marrow biopsy are crucial for diagnosis. It can be treated with hematopoietic stem cell transplantation and ruxolitinib.
In polycythemia vera, there are increased blood cell levels due to overproduction by the bone marrow, which is a soft tissue found within the bones. Normally, about 45% of the total blood volume is made up of erythrocytes, or red blood cells, and their main function is to carry oxygen to tissues and bring carbon dioxide to the lungs so it can be expired. This value is called the hematocrit. In polycythemia vera, there's an increase in red blood cell production. It typically begins with a mutation in a single hematopoietic stem cell, which gives rise to red blood cells, white blood cells, and platelets. In 90% of the affected individuals, there's a mutation of the Janus kinase 2, or JAK2 gene. Normally, the kidneys produce erythropoietin, which is a hormone that binds to receptors on the hematopoietic stem cells and activates the JAK2 gene. When that happens, it causes a cell to divide and thus produce more blood cells. However, when there's a mutation, it keeps JAK2 gene activated, and these cells are able to divide even in the absence of erythropoietin. The mutated cells proliferate and rapidly become the predominant hematopoietic stem cells in the bone marrow. In time, these cells start to die out, and that's when scar tissue forms. At that point, the bone marrow can no longer produce blood cells, leading to anemia or low red blood cell levels, thrombocytopenia or low platelet levels, and leukopenia or low white blood cell levels. This is known as a spent phase, and once the disease is in the spent phase, it's really a different disease altogether. At that point, it's myelofibrosis. The most common symptoms of polycythemia vera are fatigue, dizziness, increased sweating, redness in the face, blurred vision, and itchy skin, especially after a hot shower. Itchiness develops due to an increased number of basophils and mast cells, which contain histamine that causes itching when released. Splenomegaly, or spleen enlargement, is also common because the excess red blood cells build up in the spleen, which usually helps with removing excess cells. High turnover of red blood cells can cause buildup of uric acid, which leads to the inflammation of joints or gout and kidney stones. Individuals with polycythemia vera are more prone to blood clots and their complications like stroke, heart attack, deep vein thrombosis, and Budd-Chiari syndrome, which is when the liver veins are blocked by a blood clot. Sometimes the disorder can be found during a routine blood test. Common findings include increased hemoglobin, or hematocrit levels, as well as an increased white blood cell and platelet count. Most individuals have decreased erythropoietin, but some individuals have normal or even elevated erythropoietin levels. Bone marrow tissue examination or biopsy can be done to look for signs of fibrosis, and genetic testing can be done to look for the JAK2 gene mutation. Most individuals require phlebotomy, which is when the blood is drawn through a vein and removed every few months. This blood isn't donated for other individuals, but can be used for autologous donation, so the donor can use it in the future if needed. Myelosuppressive medications, like hydroxyurea, as well as a JAK2 inhibitor, ruxolitinib, can be used to lower red blood cell formation. Ruxolitinib is also particularly helpful with relieving symptoms like itching. Other medications that can also help relieve symptoms include antihistamines, hydroxyzine, and aspirin. Aspirin is also used to help prevent clotting. In the spent phase, individuals may need blood transfusions at regular intervals. Alright, as a quick recap, polycythemia vera is an overproduction of blood cells, often caused by a JAK2 mutation within hematopoietic cells in the bone marrow. It can lead to an elevated hemoglobin and hematocrit and predispose an individual to developing blood clots. Treatment includes removing blood at regular intervals, medication to lower blood cell formation, and prevention of blood clots. Patients may progress to myelofibrosis, which represents a spent phase of the bone marrow, where individuals may need blood transfusions or more aggressive therapy.